There's nobody on this thing. Because it's already past time. Okay. Good evening, everyone. I am Dr. Evelyn, and good evening, everyone. I am Dr. Evelyn, and today we're going to talk about CKD in the young. First of all, I want to apologize for the lateness in timing. It was due to network problems within our area. Thank you so much for joining in to the program. We're going to have a very short lecture on CKD in the young because it's becoming very prevalent in the environment. A lot of young people between the ages of 18 and 45 are having kidney diseases, and people don't understand why. They don't understand why the population of people with nephropathy is occurring more in the young than in the elderly like it used to be in the past. So this lecture is to help to explain issues to everyone. Thank you for joining in. I will not share my screen. Okay, so chronic diseases in the young, that is the topic, the silent threat no one is talking about. I'll continue. So if you're watching from Port Harcourt, Owerri, Aba, Lagos, Abuja, Kano, Bauchi, Accra, Dakar, London, or New York, this teaching is for you. Please share this link to this live on your timeline and groups you belong to on social media. Chronic kidney disease, that is CKD, is defined by KidneyGo as a structural or functional kidney damage and or an estimated glomerular filtration rate less than 60 ml per minute per 1.73 meters per for 3 months or more. Now, GFR, that is the glomerular filtration rate, is an estimated function of the kidney. So it's either the kidneys are damaged structurally, probably when you do an ultrasound scan or a biopsy is taken of your kidney and there's a damage seen, or the kidneys might look fine on scan or any form of imaging, and then they are not functioning properly. Now, let's look at the numbers, the epidemiology. What do they say? The prevalence in Nigeria by region. So, based on studies that have been done by some people and a lot of people, the prevalence in the southeast and southwest seems to be approximating. And then we found that we have more people with CKD young in the north central. Now, looking on the left side of the slide, we could see that younger people will have CKD more in the young in people living in Nigeria, in our country. So it means we have a burden that we need to solve, that we need to sort out. Globally, over 850 million people live with chronic kidney disease. And in sub-Saharan Africa, prevalence is about 13.9%. I had mentioned initially in our previous slide about that about 11.4% of people in the southeast, in this southeast where already cited, have chronic kidney disease. Like I mentioned earlier, we have more people in Nigeria having CKD in the young, a mean age of 49 plus or minus 13 years. In a previous study done by Alobiosi and Co. in Shagamu in the western part of Nigeria, it showed top causes of ESKD as glomerulonephritis, hypertension, and diabetes. This is a massive economic burden. Okay. And then it would mean that in younger people there will be a higher mortality. And of course, morbidities that are associated with kidney disease, like cardiovascular diseases, anemia, and loss of productivity, both in their functional work, in their social work, would be more increased in such people. Now, let's look at the etiology. We have 8 key drivers according to the current global data. There are 8 drivers of chronic kidney disease in young people. Number one amongst the which has the highest incidence rate is 38 to 40 is the congenital anomalies of kidney and urinary tract. Where there's an abnormality of the kidneys, the urinary tract, where urine is formed, how it passes through, the person is born with that abnormality, and this occurs in about 38 to 44% of people. Then the next is what we call the glomerulonephritis. This is the one we find it a lot in a clinical setting in people within the ages of from the age of 20 and above. You can even see it in younger people too. And the incidence rate here is 24 to 28%. Then the hereditary diseases that run in the family, just like the autosomal dominant polycystic kidney disease, where people are born with a lot of cysts. Then, of course, there is the CKD of unknown origin. That is, they would have checked the doctor or the physician would have looked through, or the nephrologist, and they can't actually find the particular cause or the specific cause of the chronic kidney disease in these persons. Then, of course, we have the hypertension, diabetes, infectious diseases like HIV, hepatitis B and C, or adding to the causes of CKD in the young. Now, in 2004 to 2014, we are going historically now. 2004 to 2014, it was an era where it was all about glomerulonephritis. That is, the kidneys will just, let's use the layman language, spoil. And then the problems are within the kidney. The kidney is the cause of the kidney problem is from the kidney. Then going towards 2014, 2024, we start having more causes from congenital abnormalities. Start noticing actually more causes, maybe following improvement in imaging, improvement in investigations, improvement in research. We now started to notice the congenital abnormalities in the urinary tract and in the kidney. Now, with urbanization, it has driven into, or it has there's now a shift in the causes to metabolic causes like diabetes and hypertension. So it's not unusual to find people of 18, 19 years, 20 years, 25 years coming to the clinic and complaining about their blood pressure. Or sometimes they could just come in for other issues. The moment they check their blood pressure, it is high. And if they don't know, these things could go on to cause kidney damages in them. Now, for the ones I talked about when I said people could be born with it. Now we'll have the genetic one. For example, the polycystic kidney disease, where the person has a lot of cysts, pockets of fluids in the kidney, multiple pockets of it. Usually, it follows the family line. A parent may would have it, the offspring may have it. It's a dominant thing, so it may occur in all generation. Then there's also the sickle cell disease causing kidney problem. Then we also have sometimes in a family you go find out that people are having kidney disease not because of something genetic, not because it's in their DNA, it's in their gene, following a bloodline. No, it is actually because they are used to a particular habit in the environment, maybe high salt intake, or in their family they take up a lot of herbal medication. Maybe the mother will cook and give to the daughter or give to the son or the husband. Do you understand? They end up having that. And or a lot of people in that family having hypertension or diabetes, and it now follows that, and if it's uncontrolled, it now follows that people in that family may end up having a kidney disease. That's what we call familiar pattern. Now, if there's a family history of kidney disease, we should know that it will increase the risk by 2 to 3 fold. It's not about destiny, it's about something that we see. Someone will say, oh, it is in your destiny. Not that. It's just about the environment, social pattern, or in the genes, genetics. So it's important to do early screening. If you find that in your family or amongst your relatives, your offspring or siblings, or even your friends, people are going down with kidney disease, you need to go for early screening. Now, the other signs, apart from the fact that it might just be there in the family, you should still worry if there's fatigue, if your urine is foamy, if you're beginning to have headaches, people with irregular women with irregular periods, you're beginning to itch, or your legs even start to swell. Then, of course, persistent blood pressure in a young person who's having hematuria, blood in urine, or BP that is not being controlled by medication, resistant blood pressure, or they suddenly do a kidney test and find out their estimated glomerular filtration rate, the function of the kidney is reduced. You should go ahead to do some screening, check your blood pressure, check your blood sugar, check your urine, check your kidney function by checking the creatinine or protein in urine. Now, or protein in urine, but most importantly, you have to visit a doctor. If there's a nephrologist around you, that's the best person to see. If there's a family history or genetic history, or in fact, I think generally for everybody living in Nigeria, once should get up to the age of 18, you should at least have a year's, at least an annual screening of the kidneys. Now, let's look at these cases. We have a 24-year-old male You have a 24-year-old male Okada rider who works 12 hours a day, drinks less than 1 liter of water, and from pain, from driving Okada from morning to night, he starts to take tramadol. His checks is the next thing is, of course, he's dehydrated, there is heat stress, and then the issue of taking tramadol. And he would also add NSAID, that is ibuprofen, the usual one we get from the chemist. And next thing, the glomerular filtration rate is going high and going low, and they're just appearing and they have to dialyze. Or a female course member who is having lupus symptoms, probably having pains, rashes, and start to take herbal medications, they would present with kidney failure. So right now we are going to go on a short break. We'll go on a short break. Let's digest what we've said. Just a few more minutes, and we'll come back. Thank you. Okay, sorry, I didn't actually know my screen wasn't being shared. So we'll just have a recap, please. So, like I said, we'll do a recap, please. A quick recap of everything. All right. So, our topic is still CKD in the young. And I had talked about, I had welcomed all of us and I had defined chronic kidney disease by KIDIGO guideline as a structural or functional kidney damage. That is a damage in the structure. When you do a scan or you do a kidney function test and there is a problem, there's an abnormality, or the functional rate, the estimated function of your kidneys are less than 60 mil per minute per 1.73 meters squared. Then I had showed us this initial slide about the epidemiology and the fact that we have more people, like if you look at it globally, in the US or Europe, kidney disease is more prevalent in people older, people 60, people who are 65 years and above. But in Nigeria, it is amongst young people. You find it more in people who are between the ages of 18 to 49. And CKD generally in our country, we'll have it more in people in the north central. For southeast and southwest, it is equilibrating. Then it's important for us to note, like I had mentioned earlier, that globally we have about 850 million people living with chronic kidney disease. Then I had mentioned the age prevalence in the young in our environment in Nigeria. And of course, it would mean that there will be more morbidity of cardiovascular diseases, anemia, loss of functional productivity, loss of social life, or reduction in social life in these people, meaning that they will have more decades of suffering if they are diagnosed with CKD at a younger age. Okay, now we're back to etiology. I had mentioned earlier, and I'll recap that the top drivers are congenital abnormalities. Etiology means causes. Congenital abnormalities of kidney and urinary tract. Then we'll have glomerulonephritis, where the primary problem is in the kidney. Then there's also hereditary or genetic causes. For example, polycystic kidney, where people have pockets of fluids in the kidney, the way they say it runs in the family. Then there's also chronic kidney disease of unknown cause. They've checked everything and they can't find what the problem is. Of course, this does not include when CKD is caused by environmental factors like stress, stress of work, stress of the sun, or the use of plastics. Then, of course, we'll have the metabolic ones like diabetes, the hypertension, the infectious, where you group the HIV, hepatitis B, and C. Then the next is important, like I said historically, before the advent of imaging, when we now studying better imaging, better recession, or we used to think, oh, the problem is just the kidney, glomerulonephritis. Now know that certain things like abnormalities, when people are born with abnormal kidneys or urinary tracts or even bladder, it can cause them to have a chronic kidney disease. Then, of course, with urbanization, like I mentioned earlier, we have metabolic things like diabetes and hypertension all coming together to worsen these issues. We are not this day. We don't get surprised when we find young people coming into the clinic with hypertension and diabetic as a problem. And then I had tried to delineate genetic from familiar. Genetic is in the gene. It runs in the family through the bloodline, like the polycystic kidney disease I mentioned, or when somebody with a sickle cell disease develops kidney problem. It's different from a familial thing. When something is going on in the environment, maybe in the family or within that set of people, they take a lot of salt, they love to take herbal medication, or they self medicate. Such people may end up having a chronic kidney disease. It's not like it's from village people, it is from habits. And so that's an environmental factor. Of course, if there's a family history, it increases the risk by 2 to 3 fold. Clinical features that we should look out for: leg swelling, irregular periods in women, when you have resistant headache, poor appetite, wake up at night, urinate a lot, up to 3 or 4 times at night. That's not, I'm drinking excess water. You should really be sure that there's no problem. Or urine gets foamy. Then, if you see this warning signs, you check your blood pressure, you should check up your urine and do a kidney test. Okay, I stopped at the VG. Now, let's talk about the 7 kidney rules from KIDIGO and World Health Organization. Now, it's important, like I had mentioned earlier, from the age of 18, you should screen. Start to check your BP yearly, check your blood sugar, even if it's once a year, check it. Yes, you're young, you're lively and all. There are no worries in the world, but you need to do an annual kidney check. The way we do it in medicine, once a year on your birthday, do a blood pressure check. Reduce your salt, your seasoning. If it's possible to avoid soda, avoid soda drinks. That's wonderful. Now, for people who work outdoor, at that point, 3 liters of water will not even suffice. It should go higher. Avoid herbal medication. Most of these herbal medication, they fix it in alcohol. They're alcohol based, and they end up destroying the kidney. Your lifestyle should be modified. Exercise at least 30 minutes, 3 to 5 times a week. Then you should avoid smoking. Limit your alcohol use. And then if you have a problem, you visit the right professional, the right doctor. Meet the doctor. Don't go. A lot of people come into the clinic, they will tell us, you've been sick. What happened? I was going to the chemist to take on drugs, to buy drugs for myself. They will check my BP, they will check this. That's not management. Some of these people will give you pain medication that will do further harm to your kidneys. All right. So, like I said, check your BP yearly, your blood sugar, eat smartly, hydrate well, hydrate safely, avoid herbal medication, even the NSAIDs, that is ibuprofen, diclofenac, those drugs. Make sure they are prescribed by a doctor and follow the prescription. Lifestyle modification, exercising 30 minutes, at least 3 to 4 times, 5 times a week. Avoid smoking, limit alcohol intake for your heart and kidney protection. Then, of course, if you're on medication, you comply with the medications and management plan. Now, when to see a nephrologist? You should see a nephrologist at once you suspect that you have a problem or you have this one inside, see a nephrologist. Another thing is, because in the environment people are not used to doing annual investigation, it could be with economic thing, it could be with economic stress and all. It's best once in a year you visit and say, please check my kidneys. What is wrong with me? Can I check? And when you go, you ask, what is my EGFR, the functional state of your kidney? What is it? What is the stage of your EGFR? Is there protein in your urine? You don't have to wait for your urine to be foamy. Go and check, find out. Ask the doctor, am I anemic? Does it look like I lack blood? These are things you find out. You want to now check other things. Do I have HIV, hepatitis B and C? You want to rule that out. Am I diabetic? It could happen at any age. Am I hypertensive? Do I have high blood pressure? Those are the issues. These are things you try to find out from the nephrologist or from the kidney doctor when you visit. Now, we need to destroy the myths and establish the facts. The myth is we say only old people get CKD. That is a lie. The mean age in Nigeria, as you've seen in my previous slide, is 49 years. These are evidence-based studies done by researchers in the country. So you can imagine at the age of 49, when the life of most people in the country are just starting, are just starting, you know, then at that point the person is diagnosed with chronic kidney disease. And that myth is herbs are natural, so they are safe. No, herbs are not natural. People will tell you mix ginger, mix garlic, mix this. We don't even know how safe they are with the mixture. It's not that they are not good, but then mixing them without being sure of their composition and their volume is the problem. You understand? Then, of course, you see people on the road carrying things on their head, moving with it, and there are people who wake up in the morning, that is their first morning drink, even before they brush their teeth. Please, herbs are natural and they are safe, but if they're in those compositions and prepared unhygienically without being sure of their composition, their volume, and or they are unsafe. And the fact is that herbal nephropathy is a documented cause of kidney injury. Then, like I said earlier, you don't have to wait for your urine to be foamy or for your feet to be swollen for you to meet the doctor. Just do your annual check. CKD is silent until it's late. So if we're going home this week, 3 things we should go home with. You check your BP. Any pharmacy around you, I'm not even saying go to the clinic, go and check your BP. Ask your family, find out from your family, do you have a history of kidney disease? A history of those fissures. They may not have known it was a kidney disease. Some of them will tell us, oh, the person's abdomen was swollen and they died. Find out if those fissures are prevalent in your family. If at least do your blood and urine test, but like I said earlier, just do it annually, even if there are no problems. Then please tag 3 people, share this. Prevention starts with knowledge. Thank you for watching. These are my references. Thank you. So I'm waiting for questions. If there are questions, I would love to respond to questions.